Imagine going to the doctor and, telling them that sitting at your desk feels like resting your body on a bed of hot nails.
Yeah, that's a visceral image.
Right. But then you mentioned that the very moment you sit on a toilet seat, the pain just completely vanishes.
I mean, it sounds completely bizarre. You would totally expect a doctor to look at you like you have two heads.
Exactly. But to a pelvic pain specialist, that one incredibly specific, frankly weird detail isn't a contradiction at all.
Not at all.
It is basically a massive flashing neon sign pointing directly to the problem. Because, usually when we talk about a medical diagnosis, there's this expectation of mechanical precision.
Right, like a clear-cut answer.
Yeah, you break your arm, the x-ray shows that jagged white line, and the doctor just points at the screen and says, there it is, it's binary, broken or not broken.
And we find that comforting, I think. We really like things to be visible, to be categorized neatly into boxes.
For sure. But then you step into the world of chronic neurological pain, and suddenly that x-ray machine is, well, it's pretty useless.
Completely useless in this case.
Yeah. We're looking at a diagnostic landscape that is incredibly murky. So welcome to this deep dive. Today, our mission is to cut right through that murkiness.
Which is quite the task.
It is. We are synthesizing a massive stack of complex medical material today. We've got clinical guidelines, some really dense anatomical studies, pain society news, and a bunch of recent medical reviews.
It's a lot of ground to cover.
It really is. And we're doing this to understand a highly specific and honestly intensely misdiagnosed condition. We are focusing on pudendal nerve entrapment within Alcock's canal.
Right.
And more specifically, we're looking at exactly how this entrapment alters your pain pathways during two very specific activities, which are sitting and deep intercourse.
It really is a profound look into how our anatomy handles physical load. We tend to think of our bodies as these endlessly resilient machines.
Actually, usually are.
Usually, yeah.
Yeah.
But we had to ask what actually happens when the body's internal wiring gets physically trapped by its own rigid structure.
And it gets ugly.
It does. By the end of this deep dive, you're going to understand not just the clinical what's of chronic pelvic pain, but the intricate mechanical and neurological why behind it.
Okay, let's unpack this, because before we can understand why the simple act of sitting down or, being intimate triggers such absolute agony for these patients, you first have to understand the geographical minefield that this nerve has to navigate.
Oh, absolutely.
I mean, it is a treacherous path.
The pudendal nerve is an anatomical marvel, truly, but its complexity is kind of its downfall here. It originates deep in the sacral plexus.
Right at the base of the spine, basically.
Exactly, drawing from the S2, S3, and S4 sacral nerve roots. And what makes it so vital, and honestly so vulnerable, is that it is a mixed nerve.
Which means it's doing multiple jobs at once.
Precisely. It consists of about 80% sensory fibers, which handle all feeling and pain perception, and 20% motor fibers, which are controlling muscle movement.
Okay, so feeling and moving.
Right, but on top of that, it also carries crucial autonomic fibers. Those manage all the involuntary background functions of the pelvic organs.
So it's basically the master control cable for the entire pelvic region. I mean, it's doing all the heavy lifting, feeling, moving, keeping the automatic systems running.
Yeah, and it has to route all of that complex information through a really crowded, constantly shifting pelvis.
Which sounds like a design flaw, honestly.
Well, it certainly causes problems. After it branches off those sacral roots, it exits the pelvis through the greater sciatic foramen. And almost immediately, it has to squeeze through this anatomical clamp between two major ligaments.
The sacrospinous and sacrotuberous ligaments, right?
You got it. That scissor-like intersection is a very common site for the nerve to get pinched. But the journey gets worse.
Of course it does.
Yeah. It then re-enters the pelvis and travels into a structure called Alcock's Canal.
Right, Alcock's Canal.
Oh.
Also known as the Pudendal Canal in some of the sources. Now, reading through the medical literature, this is where things got really dense for me.
It gets very technical very fast.
Yeah, the textbook anatomical definition is that it's I want to make sure I have this right. A narrow fascial tunnel formed by a duplication of the aponeurosis of the obturator internus muscle located on the lateral wall of the istiorectal fossa.
Right, which is an incredibly dry way to describe a very dynamic part of the body.
Wait, time out. Aponeurosis. Istiorectal fossa. Let's translate that into plain English for a second. Where exactly in the body are we right now, and what does this canal actually look like?
Fair enough. Let's break it down. Think of the inside of your pelvis like a bowl made of bone and muscle.
Okay, got a bowl in my head.
Deep inside that bowl, running along the side walls, you have this thick muscle called the obturator internus. Alcock's canal is essentially a tight, rigid sleeve of connective tissue that is glued directly to that muscle.
So it's basically a tunnel running along the inner wall.
Exactly, it's a tunnel.
You know, the visualization that helped me make sense of this from the sources is imagining Alcock's canal as a piece of heavy-duty, unforgiving metal conduit pipe.
That's a great way to picture it.
And the pudendal nerve is this highly sensitive, live electrical cable that is just forced to run right through it.
Yes.
So if that conduit pipe narrows because the surrounding muscle spasms, or if the cable gets pulled tight because your pelvic mechanics shift, the whole system just short circuits.
Right, because it's trapped in a tunnel that absolutely refuses to stretch or yield to the nerve.
It's just a rigid trap.
That analogy hits on the exact biomechanical problem. What's fascinating here is that the stakes of that short circuit are incredibly high because of what happens the very moment the nerve exits that unforgiving pipe.
Oh, because it splits up. Right.
Exactly. Inside Alcock's canal, the pudendal nerve divides into 3 terminal branches.
Okay, what are they?
First, you have the inferior rectal nerve, which supplies the anal canal and external sphincter.
Okay.
Second, the perineal nerve, supplying the perineum, the lower vagina or scrotum, and the urethral sphincter.
Wow. Okay, so a lot of real estate.
Tons. And third, the dorsal nerve of the clitoris or penis.
So it splits into its final destinations right inside this rigid trap. I mean, meaning if it gets pinched inside the canal, everything downstream goes completely haywire.
It casts a massive net of dysfunction. And entrapment in Alcock's canal doesn't just cause a localized pinpoint ache.
Right. It's not like hitting your funny bone.
Exactly. You have sensory, motor, and autonomic fibers for the bowel, the bladder, and the sexual organs all getting crushed at a single, completely unavoidable choke point.
Which perfectly sets the stage for the specific pain triggers the sources talked about. Let's look at the geometry of sitting.
Yeah, this is crucial.
Because understanding this rigid, tight conduit explains why the simple, everyday act of just pulling up a chair becomes a mechanical trigger for intense nerve compression.
When you sit down on a standard flat surface, especially for prolonged periods of time, or, if you engage in activities with repetitive microtrauma to the perineum, like cycling.
Oh, cycling's a huge trigger, right.
Massive trigger. When you do that, you're introducing a massive amount of direct upward physical pressure against Alcock's canal.
If you look at the pathophysiology of what's happening inside that canal when you sit, it's actually brutal. The sources say the compression immediately causes venous stasis.
Right. The veins literally can't drain.
Because of the pressure.
Yeah, they're being physically squeezed shut by your own body weight pushing up against the chair. So the blood just starts pooling inside the canal.
And that pooling leads to increased vascular permeability. Basically, fluid starts leaking out of the blood vessels into the surrounding tissue.
Exactly.
So now, inside this rigid pipe that already can't expand, you have a ballooning physical swelling.
It's a pressure cooker. And this constant pressure and inflammation eventually leads to demyelination.
Let's break that down, because demyelination is such a critical concept here. If we go back to our electrical cable analogy.
I'm perfect for this.
Yeah, demyelination is like taking a knife and aggressively scraping off the rubber insulation surrounding a live wire.
That is exactly what is happening on a cellular level. The myelin sheath is a protective coating that allows nerve signals to travel smoothly and quickly.
Right.
When the pressure and swelling strip that coating away, the nerve gets scarred. It's a process called fibrosis.
And so the signals can't get through properly.
Neural conduction becomes severely impaired, the nerve is actively damaged, and it just starts firing off chaotic distress signals to the brain.
And patients experience this as severe neuropathic pain. The clinical guidelines describe burning, shooting, stabbing sensations, or feeling like they're getting electric shocks deep in their pelvis just from sitting down.
It's horrific for the people experiencing it.
One of the most baffling things I read in these medical reviews, though, was a symptom called allotriesthesia. Have you come across this?
The sensation of a foreign body, yes, it is remarkably common.
I was reading patient descriptions, and it honestly stopped me in my tracks. People literally feel like there's a golf ball or a tennis ball permanently trapped inside their rectum or vagina.
Yeah, a golf ball is the most common comparison.
But physically, medically, when doctors check, there is absolutely nothing there. How on earth does a crushed nerve create a phantom golf ball?
It all comes back to the brain trying to make sense of chaotic data.
Okay, how so?
Well, the pudendal nerve is so irritated, and that protective myelin coating is so damaged that it is constantly misfiring. The brain receives this barrage of intense pressure signals from the pelvic region.
Just constant noise.
Right. And since the brain relies on past experience to interpret sensation, it concludes that there must be a physical object applying pressure from the inside.
Oh, wow.
Yeah, it is a hallmark of pudendal neuralgia. The brain is literally manifesting a physical shape to explain the internal nerve damage.
That is just wild. But I want to push back on this sitting mechanic for a second because this brings us back to that massive contradiction we opened the show with.
The toilet seat.
Yes.
Yeah.
We just established that sitting causes this extreme upward pressure, venous stasis, swelling, and agonizing pain.
Yes, we did.
But the clinical diagnostic guidelines specifically note that sitting on a toilet seat provides immense, almost instant relief for these exact same patients.
It does.
Wait, if sitting down is the root cause of all this pressure and pain, why does sitting on a toilet seat make it go away?
It seems like a paradox, I know, but it beautifully confirms the mechanical nature of the entrapment. Think about the physical geometry.
Okay, I'm thinking about it.
When you sit on a standard, flat chair, your pelvic floor and your perineum bear the brunt of your body weight pushing down against the flat surface pushing up.
Right, the tissue is sandwiched.
Exactly. It directly crushes Alcock's canal and the pudendal nerve against your internal pelvic bones.
The pipe gets squished against the bone.
But look at the geometry of a standard toilet seat. There is a void in the middle.
Oh, because of the hole.
Right. When you sit on a toilet, your body's weight is entirely redistributed away from the center of your pelvis and out to your ischial tuberosities.
Ischial tuberosities.
Those are the bony protrusions you might know as your sit bones.
Ah, okay. So the center of the pelvis, the perineum, isn't actually touching anything at all.
The pelvic floor is allowed to just suspend freely in that empty space. There is zero upward pressure crushing Alcock's canal.
Wow.
The nerve is suddenly decompressed, the veins can finally drain, and the pain rapidly subsides. This phenomenon is so mechanically specific and so reliable that it forms a core part of the Nantes criteria.
The Nantes criteria, let's define that for the listener since it came up a lot in the sources.
Sure. It is the global gold standard set of diagnostic criteria used by specialists to officially diagnose pudendal nerve entrapment.
So it's basically the checklist.
Exactly. If a patient comes into a clinic and says their pelvic pain is an absolute 10 out of 10 when they sit at their office desk, but drops to a 0 when they sit on the toilet,
The doctor knows exactly what it is.
a specialist doesn't even need an x-ray. They immediately know to look at the pudendal nerve inside Alcock's canal.
That is just incredible. It's a purely mechanical diagnostic tool. You change the physical load bearing and the nerve gets a breather.
It's a very elegant clue.
But sitting is just an external pressure. We also need to talk about what happens internally. Because Alcock's canal isn't just a bone tunnel, it's made of dynamic muscle tissue.
Right. We mentioned earlier that the canal itself is formed by the fascia of the obturator internus muscle.
Yeah, that thick muscle on the side of the pelvis.
Right. This is a deep pelvic muscle that doesn't just sit there doing nothing. It actively helps rotate the hip and stabilize your entire pelvic floor during movement.
So if the canal is essentially made of active muscle, what happens when those muscles are forced to move or stretch during physical intimacy?
That's where the second major trigger comes in.
Right. This brings us to deep dyspareunia, which the medical sources define as pain occurring with deeper sexual penetration. This is directly linked to restriction and dysfunction in the deepest part of the pelvic floor.
Yes. During deep intercourse, muscles like the obturator internus and the iliocotachus have to physically stretch and accommodate.
Which is supposed to be totally normal?
In a healthy pelvis, this internal movement is completely painless and natural. But if the pudendal nerve is trapped, inflamed, and stripped of its myelin inside Alcock's canal, any internal stretching of that obturator internus muscle pulls directly on that damaged nerve.
Oh, man. It's like pulling on that exposed, short-circuiting electrical cable from the inside.
Exactly. And that internal physical stretch triggers severe acute neuropathic pain. But the devastation goes beyond just the immediate mechanical stretch.
It starts a chain reaction, right?
It creates an escalating physiological nightmare.
Yeah, a vicious cycle in the pelvis. When you read the literature on pelvic floor dysfunction, they call it a merry-go-round effect.
Which is a very innocent name for a terrible process.
Seriously, the intense nerve pain from the stretch causes the pelvic muscles to instinctively clench up to protect themselves. It's involuntary muscle guarding.
The muscles basically go into hypertonicity, or severe spasms,
And because Alcock's canal is literally formed by those very muscles, when they spasm and stay hypercontracted, they squeeze the canal even tighter around the nerve,
which further compresses the pudendal nerve.
causing even less blood flow, more ischemia, and even more intense pain, which then tells the brain to clench the muscles even harder.
The patient is just trapped in this endless feedback loop of muscle tension and nerve crushing.
If we connect this to the bigger picture, we have to look at what this endless loop does to the central nervous system over time, because it doesn't just stay in the pelvis.
No, it spreads. There is a neurological concept called central sensitization, sometimes referred to as wind-up.
Wind up. That sounds incredibly ominous.
It is the nervous system's darkest trick, honestly.
How does it work?
Well, when you have a trapped peripheral nerve firing off nonstop distress signals, day after day, month after month, it literally bombards the spinal cord.
Just relentless signaling.
Right. This constant barrage causes an exaggerated release of a neurotransmitter called glutamate in the spinal cord.
Okay, glutamate. And that acts as an excitatory neurotransmitter, right? It ramps things up.
It floods the system. It upregulates NMDA receptors. The spinal cord essentially adapts to this constant state of emergency by becoming hyper-efficient at transmitting pain signals.
So it's learning to feel pain better?
Yes. Yeah. It turns the volume dial on pain all the way up and literally snaps off the knob. It fundamentally lowers your pain threshold.
Wow.
This literally rewires the central nervous system, creating a state known as allodynia.
Allodynia, that's a term that kept popping up in the clinical reviews we looked at. That's when a normally completely non-painful stimulus is suddenly perceived as agonizing, right?
Exactly.
Like a feather touching the skin feeling like a blowtorch.
Because of this rewiring, the
Yeah.
brain starts interpreting any sensation in the pelvic region as a severe threat.
Anything at all?
Anything. Normal sexual touch,
Yeah.
natural physical arousal, or even just the friction of your clothing as you walk around. Sensations that should feel fine or even pleasurable are amplified by the sensitized spinal cord and perceived by the brain as traumatic pain.
So what does this all mean for the person actually living with this? It means the brain is essentially being tricked by its own neuroplasticity.
Yes, that's exactly what's happening.
What started as a purely mechanical trap in the pelvis, a squeezed pipe, has turned into a systemic blaring alarm bell that completely ruins intimacy, even if the physical pressure is incredibly light.
The nervous system's attempt to protect the body goes into complete overdrive and turns against the patient. Remember, early on, we established that the pudendal nerve also carries autonomic fibers.
Oh, right, the automatic background functions.
Yeah, so this central sensitization can bleed over into the autonomic nervous system through neurocrosstalk.
Which leads to conditions like PGD, which was heavily discussed in the sources.
Persistent genital arousal disorder. It is a form of severe arousal dysfunction.
And how does the entrapment cause that exactly?
Because the autonomic fibers are misfiring from the compression and the spinal cord is wound up, the patient might experience a constant, intrusive, and incredibly painful sensation of sexual arousal.
But without any actual sexual desire or external stimulation.
Right. It is purely neurological crosstalk. It severely impacts the patient's quality of life, their mental health, and their most intimate relationships.
It is just devastating to think about. I mean, to have an essential part of your human experience, intimacy, or even just the simple ability to sit down at a dinner table with your family, completely hijacked by this invisible internal clamp.
It takes a massive toll.
To summarize the incredible journey you've taken with us today through these medical sources, we started at the structural trap of Alcock's canal, understanding how the pudendal nerve, our vital electrical cable, gets caught in that muscular conduit.
The anatomy really is the foundation.
Exactly. And then we looked at the biomechanical forces of sitting down, how upward pressure strips the nerve of its insulation, and how the bizarre toilet seat phenomenon beautifully proves the mechanical nature of the entrapment.
Such a key diagnostic clue.
And finally, we explored the internal mechanics of deep intercourse, how the stretching of the obturator internus muscle triggers a vicious cycle of spasms, which ultimately leads to central sensitization, rewiring the spinal cord so that the brain turns normal human touch into agony.
It is a staggering interplay of anatomy and neurology. But I want to leave you with a final thought to ponder, drawn from the sources that discuss the psychology of chronic pelvic pain.
Oh, this is a fascinating angle.
It really is. We know that neuroplastic changes in the brain, specifically in an area called the ventromedial prefrontal cortex, which drives our emotional and behavioral responses to pain, are heavily influenced by language and environment.
Wait, the actual words we use to communicate about our pain?
The words we use and the cultural context we find ourselves in. The clinical literature notes that individuals with chronic pelvic pain frequently report deeply unsatisfactory conversations with healthcare providers.
Because it's an awkward topic.
Right. They feel misunderstood, dismissed, or stigmatized because the pain involves sexual organs or bowel functions. This negative, stressful interaction alters those top-down regulatory pathways in the prefrontal cortex, increasing physiological stress and actually amplifying the biological perception of pain.
So the societal stigma makes the pain biologically, physically worse.
It does. So the challenge to consider is the reverse.
Okay, wait more.
If the brain's top-down regulatory pathways can alter how we process pain for the worse, could changing our societal language create a positive biological effect?
Oh, wow.
Could removing the stigma around pelvic and sexual health and having empathetic, validating conversations with healthcare providers actually reorganize that prefrontal cortex?
That's a huge question.
Could the simple act of feeling believed and understood downregulate the nervous system enough to physically reduce the severity of these nerve entrapment symptoms?
It is a powerful reminder of just how deeply the brain and body are connected. At the start of this deep dive, we talked about how comforting a clean, broken bone on an X-ray can be.
Yeah.
Simple.
Yeah, it is. But pudendal nerve entrapment in Alcock's Canal isn't like that. The diagnostic waters are murky, the nerves are hidden deep inside the pelvis, and the pain is completely invisible to the outside world.
But it's very real.
It's very real. Just because we can't always see the break on a screen doesn't mean the conduit isn't actively crushing the cable. And maybe understanding the mechanics of these murky waters and finding the vocabulary to talk about them without shame is the very first step to finally clearing them up.